I am Dr. PIYUSH DESAI. I am consulting diabetologist and endocrinologist practicing at Surat.
How does Imeglimin fit into your regular practice with the current landscape of T2DM treatment options? Kindly share your experience.
As type 2 diabetes is a chronic and progressive disease, so basically we need multiple agents to treat this. At the same time, it's a polygenic disease, mechanisms which are playing crucial role in type 2 diabetes pathology. Up till now, we have few drugs to target insulin secretion or insulin production, and there are few drugs which are good for insulin sensitization. But as far as sensitization is concerned, we are having only two specific drugs which is left in market, and that is metformin and pioglitazone. So for sensitization, which is playing a very crucial role in early type 2 diabetes or obese type 2 diabetes, we need more drug for that. And I think Imeglimin is adding to this list, going through a different pathway, having also action on mitochondria, which no other drug is playing role, and it's a good addition to existing treatment for control of diabetes.
In what specific patient populations do you see the greatest benefit of using Imeglimin?
I will say obese patient, new onset type 2 diabetic patient, or even patient with pre-diabetes where there is severe insulin hyperinsulinemia or insulin resistance, where we can give Imeglimin. At the same time, as standard of care, metformin is the first drug to use as an insulin sensitizer. But what happens that few patients are not tolerant to metformin because of gastric side effect. These are also a good candidate patient for using Imeglimin in their prescription.
How does Imeglimin compare to other hypoglycemic agents in terms of safety and efficacy? Kindly share a real world case if any.
We don't have very big CV outcome study data, or we don't have very extensively studied data with Imeglimin. But whatever real world data are there with Imeglimin, it's quite a safe and a good drug. As far as side effect profile is concerned, hardly there are patients who are suffering for gastritis or gastric related side effect, which is negligible. At the same time, there is no risk of hypoglycemia by virtue of its action, and this drug can be combined to DPP-4 inhibitor or SGLT2 inhibitor or metformin or even glitazone without having significant interaction. So I will say, keeping the eye on overall regular practice, it's a safe and effective drug, and you can give at multiple occasions with multiple comorbidities or a co-prescription.
In recent time, Imeglimin sustained release formulation with Indian study has been launched in India. What is your opinion on that?
Yes, actually, we have past experience with metformin, that if you give metformin, which is also a very important insulin sensitizer, causing gastric side effect. And by making it sustained release or extended release, the chances of gastric side effect were found to be less in case of metformin. So I think there is a logic behind using sustained release formula with Imeglimin. You can go for sustained release if you want lesser side effect. But if you ask me, my clinical experience, actually even non-sustained release Imeglimin is very well tolerated. There are only few patients who have gastric side effect, which is far lesser than metformin.
How does the mitochondrial targeting mechanism of Imeglimin influence its clinical use?
Metformin targets liver, glitazone targets peripheral tissue. But after targeting this insulin resistance, there is a certain change which is required through mitochondria, Golgi apparatus, where all this protein generated metabolism is happening. So subcellular level, metformin and glitazone is having certain inhibition, or I will say limitation, where they will not work. So it's a good adjunct that this drug goes to mitochondria, it sensitizes mitochondria in a certain way that it improves insulin resistance, where metformin or glitazone cannot work. So So this is actually an addition to what is happening at a cellular level of insulin resistance. So it's a good add-on.
What are the key safety and efficacy findings from clinical evidences on Imeglimin that clinicians should be aware of?
See, Imeglimin reduces HbA1c of around 0.5 to 0.7, which is quite comparable to most of the oral hypoglycemic drug. This is not very potent drug and it is not a very low potency drug. It's a medium moderate potency drug. Second, this is the drug we can use when there is metformin intolerance, or even after metformin patient is not having enough insulin sensitization, where you can use Imeglimin. Now, when you are giving Imeglimin to the first time, I will suggest to start with 500 mg BD, and if needed, you can step up to the full dose of 1 gram BD, because the dosage is like similar to metformin. You have to step up to the maximum tolerable dose, and actually 1 gram BD gives you a very good effect. So don't just stop at 500 mg BD, because this is the amount of Imeglimin which is just 50% of insulin sensitization happening. So step up to the full dose whenever it is required.
Do you believe that Imeglimin has the potential to change the future landscape of diabetes treatment?
Time will tell, because I will say it's still a comparatively new molecule. We still don't have long-term data with cardiovascular benefit or renal benefit like SGLT2 or GLP-1 are already having now. So I will say yes, it can be, because it's a good sensitizer, but we need a good study to back this data of insulin sensitizing effect of Imeglimin and this. But yes, it's a good and safe molecule. So maybe in future, if everything works and if studies are showing benefit, it may become a standard of care like other insulin sensitizer in early type 2 diabetic or obese type 2 diabetes.
Any other key point or take home messages you would like to share apart from this?
Just take home message is one, that don't stop at metformin alone, because I have seen people who are just using metformin as a sensitizer. Glitazones are good sensitizer, and if glitazone is contraindicated, this Imeglimin is another good sensitizer. So whenever patients are needing more and more insulin sensitization, instead of going for sulfonylurea or other drug which is targeting more insulin therapy, go for better insulin sensitizer, especially in early stage of diabetes. That will prevent not only, that will not ultimately have a good glycemic control, but that will prevent hyperinsulinemia, which is atherogenic, and thereby we can prevent future cardiovascular disease.